Good afternoon, everyone. Welcome to the Support Hospital Opioid Use Disorder. That's Shout Texas Echo. Please note that we are recording these sessions for later distribution on the Texas Mood YouTube page. Know that your names, as you see them on this Zoom Hollywood Squares screen, do not appear in the recording of the session, nor does anything that you list in the chat. My name is Andrea Roche. I'm with UT Health San Antonio Echo, and I'll be facilitating our conversation today. Just some housekeeping. To help us with our attendance, if you could please enter your name, affiliation, and if you're comfortable, email into the chat feature. We promise not to spam you. We just use this as an accurate record of our session attendance. To access that chat feature, navigate to the speech bubble icon at the bottom of your Zoom window. And if you've joined by phone only, know that you won't have access to that, but we might call you after the session to confirm your attendance. I think that's not applicable to anybody. I think we're all joining by computer. Well, we love to see everyone's smiling faces, so if you are comfortable, we do encourage you to join by video, especially for the later part of our session, which is the discussion component. We invite everyone to speak and share their opinions and experiences, but do ask that you stay muted unless you are speaking. To mute and unmute, you can select the microphone icon at the bottom left of your Zoom window. Again, if you've joined by phone, you can use *6. Just know there's a little bit of a lag. But please do know that no PHI is allowed in the chat or in our discussions during the entire session. As I mentioned to those of you filtering in, we are recording these sessions. We do make them available on the Texas Mood YouTube page after the session. During and after the session, the Shout Texas Echo team will send along a link to an evaluation of this session, and I'll tell you a little bit more about that with Texas Mood announcements coming up a little bit later. Our didactic today is about women's health and substance use disorder in the hospital setting. Following that, we will discuss a case presented by UT Health San Antonio. So we're going to start with some introductions, followed by announcements, then our case presentation, and then finally, my favorite part, open discussion. You know, there's enough of us here. I think we can get away with doing introductions of everyone, which I love doing. Let's start with our hub team. Dr. Jan.
Hey everyone, I'm Jan Ramesh. I'm one of the hospitalists over at Dell Medical School. I'm going to be the lead specialist today. I have a special interest in substance use disorders of all types.
Thanks so much for joining us. Chris.
Hey, Dr. Chris Moriades. I am a practicing hospitalist, and I'm Assistant Dean for Healthcare Value and Associate Chair for Quality and Safety at Dell Medical School at UT Austin and part of the Shout Texas team.
Thank you. Blair.
Hi, I'm Blair Walker. Sorry, still taking all my stuff off. I'm with psychiatry at Del Seton Medical Center. I am also part of the B team here. I'm chief of psychiatry and lead the CL service line. I'm very happy to be here.
Thank you for joining us. Lorie.
Hi, I'm Laurie Harper. I'm the division chief of maternal fetal medicine with UT Seton Dell Medical School. And I have a special interest in substance use disorders and pregnancy.
Great. Melinda.
Good afternoon, everybody. I am Melinda Morales. I work with Community Action Corporation of South Texas, and I'm also CHW, and I'm out of Kingsville.
Thank you for joining us. And I'll go to some of the Texas Mood team. Alana.
Hi there, everyone. Good afternoon. My name is Alana Bolton. I'm the program manager for Shout Texas at Dell Medical School at the University of Texas at Austin, and we're so glad to see you all here today.
Thanks for joining, Alana. Andrea. Oh, Andrea, you're muted.
Okay, now. My name is Andrea Hevler, and I'm one of the coordinators for the Echo Sessions project. Thank you.
Thank you. I see an Ada Sapp.
Good afternoon. I'm Ada Sapp. I'm the psychiatric mental health nurse practitioner working with Dr. Veronica Perez at Baylor Scott and White Health in Temple.
Great. Tony.
Hello, everyone. My name is Tony Gao, the Assistant Medical Director of the South Texas Poison Center, and I'll be presenting the case. Thank you all for having me.
Thank you. Dustin.
Hi, I'm Dustin Amos. I'm the Medical Director for the inpatient psychiatric hospital at JPS in Fort Worth, and I'm leading the effort for our addiction services here at JPS.
Thank you. Emily.
Hey guys, Emily Ibata. I work at Bentop Hospital in Houston. I am the nursing program manager for maternal substance use and outreach. Thank you.
Thanks for joining. Dr. D.
Hello, I'm Dr. Dan Lapp, and I'm an addiction psychiatrist with Ms. Ada Sapp at Baylor Scott and White Health in Temple, Texas.
Great. G.L. Hernandez.
Hi, my name is Lorie Hernandez. I work out of Corpus Christi, Nueces County, mental health. I'm with OSAR. We provide outreach, screening, referrals, and assessments for adults and youth.
Thank you for joining. And I know I'm going to get this wrong, but it's RDE Freites, or you know who you are.
I'm Raquel DeFreitas. I am the NICU nurse manager here at JPS in Fort Worth, and I am part of the Texas AIM opioid bundle team.
Wonderful. Nadine.
Good morning, Nadine Scamp with Santa Maria. We are in Houston, and we're also a partner with Bentop.
Great. Thank you for joining. G. Hay. G. Hay, if you're able to unmute. Ah, there we go.
Yes. Yes, my name is Gay Hay, and I work with Hendrick Health out of Abilene in the quality department as well as with TPC.
Great. And Jen Biddle.
I'm Jen. I am an LCSW addiction recovery social worker therapist with community care clinics in Austin. And I specialize in SUD and MAT.
Awesome. And Simone.
Hi, I'm Simone Joanu, research coordinator with the HEROES program at UT Health Houston and the Center for Health Systems Analytics and the opioid-related programs.
All right. Sean Wright.
Hello, I'm Sean Wright. I'm the program director for the recovery support services at Abilene Recovery Council.
Thank you for joining. I see a few more. Sharon. Sharon, if you could use the chat to introduce yourself, we appreciate it. And at Courtois?
Good afternoon. My name is B. Briseida Courtois, and I'm part of the UT Health San Antonio, Texas Mood Group. Thank you.
Thank you. And then last, I see an Iffy.
Hi, everyone. My name is Iffy. I'm a psychiatric mental health nurse practitioner with the VA. This is my first year, so I have interest in SED.
Welcome. Thank you so much for joining. And wow, my screen filled up beautifully, so this is great. Let's get started with our programming. At this time, I'm going to turn things over to Laurie Harper, who's going to be presenting our didactics for the day. Laurie, the floor is yours. When you're ready, begin.
Thanks. So I was asked to talk about substance use disorders and women's health. But really, when we talk about that, what we really mean is pregnancy, right? Because treating a 25-year-old woman is just medically not that much different than treating a 25-year-old man. And my focus is on pregnancy, so I really shouldn't be talking about treating non-pregnant people anyway. I have like 1,000 slides, and this is a talk that is generally geared towards obstetricians to get them interested in treating people with opioid use disorders. And so I'm going to be skipping through slides. Anyone can have a copy of these. But in general, I'm just trying to describe treatment options for substance use disorders and pregnancy, and that's really the focus of this talk. And then I have slides on the other things, but we won't get through those. So I think everyone here is on board with why would we bother? It's because opioid use disorder is a leading cause of death, and that is true in non-pregnant patients. It is also true in pregnant patients. It is a leading cause of death and of pregnancy-associated mortality. It also causes stillbirth, placental abruption, preterm delivery, low birth weight, and neonatal withdrawal. 95% of babies who are exposed to opioids in utero will require treatment, and about 50 to 60% will have moderate to severe neonatal withdrawal. This is my other why bother slide. Again, I feel like I'm a little preaching to the choir here because this is a group of people who are interested in opioid use disorders, but NPR did this very wonderful series on maternal mortality in the US. And these are just two of the cases that were related to addiction. This is, like I said, accounts for 25 to, in some states, up to 40% of pregnancy-associated mortality. So when we talk about treatment options, the treatment options are the same during pregnancy as they are outside of pregnancy. And really, we don't have that many differences in what we do. Behavioral therapy is still the mainstay of substance use disorder treatment. There are no trials demonstrating efficacy during pregnancy. But again, there's no real reason to think that behavioral therapy wouldn't work for a pregnant woman just because she's pregnant. So if you would do it for a woman who wasn't pregnant, I think it would be fine and safe to do for a woman who was pregnant. Medically supervised withdrawal. So what I'll tell you is that in medically supervised withdrawal in non-pregnant patients is typically not sufficient to produce long-term recovery. There's a high risk of relapse and there's a high risk of overdose with relapse. In pregnant patients, all those things are still true. So really, for me, what you'd have to prove is that somehow those weren't true and or there's some other pregnancy-related benefit. There also doesn't seem to be any pregnancy-related benefits. So there are some case reports of stillbirth, case reports of miscarriage, case reports of low catecholamine levels, which is sort of the theoretical way that babies would have a stillbirth. Honestly, when we talk to patients about medically supervised withdrawal, my focus is really on the fact that it doesn't work and it doesn't work well. So it's not really considered a very good treatment option. The risk of stillbirth and miscarriage is, again, based only on case reports. If you look at the literature in terms of women who have been incarcerated during pregnancy and forced to withdraw, they don't seem to have a higher stillbirth or miscarriage rate than any of the rest of the population. So the risks of medically supervised withdrawal are not that unique to pregnancy. I wouldn't really focus on the stillbirth miscarriage risk, but really it's about their risk of relapse and their risk of overdose. And so this is the study I was referring to. So in this study, there were incarcerated patients, inpatients who did, or women who did an inpatient detox that got good follow-up, women that did an inpatient detox that weren't getting good follow-up, and women who were discharged home on a buprenorphine taper. And if you look, they don't look that different between groups significantly. Their gestational age at detox is a little bit different. But if you look at their pregnancy outcomes, the rate of neonatal abstinence syndrome, which is now withdrawal syndrome, so lowest in the people who are incarcerated, so they had no access, lowest in the people who had good follow-up after detox. But if you just do a medically supervised withdrawal and then don't get follow-up, their rate of neonatal withdrawal syndrome is 70%. And that basically just matches their rate of relapse. So I would consider medically supervised withdrawal in pregnancy not the standard of care. It can be considered in special circumstances. For example, women who are incarcerated and you can't get them medication, or in patients who simply will not do medication. More research is definitely needed on this area with intent to treat and appropriate comparison groups. I think that a lot of people are very interested in doing this because of the possibility of eliminating neonatal withdrawal syndrome and neonatal exposures. But I'm going to show you another slide in a minute as to why that's not quite ready for prime time. My red line in the middle is supposed to be going over NSAID. So when you're doing a medically supervised withdrawal for a pregnant woman, we still have sort of the same options for treatment of symptoms. So clonidine can be used in pregnancy for the pulse, blood pressure, anxiety, chills, and as can a clonidine patch. Benzos can be used. Not my favorite in pregnancy. There's some association with birth defects. And again, I just don't, there's going to be a different neonatal withdrawal syndrome with that. And if a patient is on particularly in the third trimester and near delivery, on benzos plus an opioid, that's significantly increasing the risk of a neonatal withdrawal syndrome. Loperamide, Imodium use at will for the diarrhea, and the antiemetics, those are the antiemetics we use in pregnancy for nausea, vomiting, and pregnancy. So those are great. And then the only other medication on here that we can't use during pregnancy is NSAIDs for pain. So they can have Tylenol, but not NSAIDs. And that's what the red line is supposed to be through. I'm sorry that it gets messed up on the slide. Another option that we have is opioid taper, which basically it's a medically supervised withdrawal, but over a very long period, as opposed to a short inpatient hospital stay. And typically this will use either methadone or buprenorphine. So again, the goal here of medically supervised withdrawal or opioid taper is to get pregnant women off of opioids in the long term, minimize fetal exposure, and decrease the risk of neonatal withdrawal. So for that to actually work, they have to be successful, right? You have to take a patient and say, I'm going to stop your buprenorphine, and you're not going to use anymore. You're not going to relapse. And of course, you never know who's going to relapse and who's not going to relapse. And what we know is that if you relapse, again, high risk of overdose and more risk of neonatal withdrawal, because the risk of neonatal withdrawal is not necessarily directly related to dose, but is related in part to the ups and downs. So the highs and the lows, as well as other medications that you might be taking. So what my team, when I was at UAB, did together was we did a meta-analysis looking for people who had compared tapers to maintenance. And we didn't find very many. So you can see there's about 300 patients included in these studies. So, and they mostly included inpatient tapers versus outpatient method maintenance. And so the risk of relapse in women who were, and this is pregnant women, who were tapered is higher in women who are tapered compared to women who were on maintenance therapy. So almost a twofold increase in the risk of relapse. But the risk of neonatal withdrawal was not decreased. So we're taking a big risk by doing these tapers during pregnancy, as opposed to continuing maintenance, and really for not a lot of benefit. You can argue, well, if you're successful, then obviously the baby is not going to have withdrawal syndrome, but that's not necessarily an option to choose. I'm going to have a successful withdrawal versus an unsuccessful withdrawal. And this is again, a set of slides that I usually use for obstetricians, and I'm preaching to the choir, but risk of relapse equals risk of death. That's sort of the point of these slides. So then we get to pharmacotherapy, which has a lot of different names. But the goal is improve health, improve daily functioning, prevent withdrawal symptoms and craving, and then it's also risk reducing. So risk reduction for HIV, hepatitis C, and the overdose. Our options, as always, are methadone and buprenorphine. And buprenorphine has, of course, two forms, with or without naloxone. Does anyone want me to actually go through the methadone pharmacotherapy? Just give a shout out if you'd like me to. It doesn't really change during pregnancy, other than to know that because it's hepatically metabolized, the metabolism is increased during pregnancy. The side effects are the same. I always tell my clinic patients it's a miracle that a pregnant woman on any kind of pharmacotherapy is ever going to have a bowel movement, and I just prophylactically start them on things. Buprenorphine, again, hepatic clearance. So again, will frequently require increased dosing compared to non-pregnant. I don't prophylactically increase people's dosing. There's a lot of questions about using the buprenorphine plus naloxone for pregnant women. Naloxone is the opioid antagonist. It's not orally absorbed. So if you think about its purpose, it's to prevent diversion, right? To prevent people from finding other ways to use their buprenorphine to get high. So as long as a pregnant patient isn't abusing it, the naloxone option is fine. What I tend to do is talk to patients about the options. A lot of patients already know the difference and have been on these before, and they have a strong preference. And so a lot of patients actually prefer, in my experience, have preferred the buprenorphine naloxone. And so I'll just keep them on it during pregnancy, and that's not contraindicated during pregnancy. In terms of what methadone versus buprenorphine look like in pregnancy and sort of prenatal outcomes. What you'll note, and this is a big randomized control trial of women who were enrolled in methadone versus buprenorphine. One thing to know about this study is a lot of the women who were enrolled to get buprenorphine ended up dropping out because they didn't tolerate the withdrawal that buprenorphine requires. But overall, the risk of neonatal withdrawal syndrome is the same between groups. So 57% for methadone versus 47% for buprenorphine, and that odds ratio crosses 1. So it's not a significant difference in the risk of neonatal withdrawal syndrome. They get a lot of press because the peak neonatal withdrawal score was lower in the buprenorphine group, and they needed less morphine and a shorter hospital stay. And so that might be clinically significant when making your choice. Their birth weight was maybe a little bit bigger for buprenorphine, and their head circumference may be a little bit bigger. Whether or not that is a clinically significant difference and how these babies will do is unclear. In terms of maternal outcomes, nothing very significant other than this very vague medical complications at delivery was higher in the methadone group. But again, I don't take that to mean that methadone is any way inferior. In terms of long-term outcomes, we just have a lot more data on methadone. And the official stance on methadone is that there appears to be no adverse long-term impact on infant neurodevelopment. Buprenorphine has limited information available. And because of the big NIH funding push to fund research in this area, we'll be seeing a lot more information in this area to come. So there's a lot of ongoing studies about neonatal withdrawal syndrome and brain development. So when choosing, so the question of how do you choose which one is best for the patient, the same thing you do when patients aren't pregnant. What is available and patient preference. I really don't let risk of neonatal withdrawal syndrome and the treatment of it drive what is best for the patient. Because again, the risk of neonatal withdrawal syndrome is similar. The way I counsel patients with opioid use disorder, so first of all, there is a small increase in the risk of birth defects with opiates and opioids. That seems to be heart and some craniofacial things. Although I will say the studies are not consistent. There is an increased risk of preterm birth, growth restrictions, stillbirth, and SIDS. And all of these things are present regardless of the form of opioid you're using. So this is true for heroin, it's true for oxycodone, it's true for buprenorphine. So these are still present with pharmacotherapy, but significantly less than with continued illicit use. And then I talk about the risk of relapse without treatment. Opioid antagonists like naltrexone are also an option during pregnancy. The trick is that, so again, agonist therapy is typically preferred because it's more effective. The unique issue of using naltrexone during pregnancy is at some point, all of your patients are going to want some form of pain control. And this is true for the injectable, that you need to stop at least 1 month before delivery, but you need to stop it before they go into labor and before they're requesting epidurals for pain control. So that's just an issue to think about and talk about with patients. Like, what are they going to do in that, particularly if they're not injectable, what are they going to do during that time period? And also to know for injectables, you never know when a patient's going to go into labor. Like, she's got a due date, but that is sort of our goal target date. Like, anybody can go into preterm labor. And so if they're on an injectable form of a long-acting form of naltrexone, they might end up laboring with no pain control. I'm going to stop there. and let people ask any questions they might have for me. Andrea, I saw my comment. I just didn't know what time it was.
Thank you so much. And we appreciate the generosity of, I mean, that was part of a much larger slide deck, and we appreciate your generosity with sharing that. I see a question coming in the chat. Nicholas, would you mind unmuting and raising that question yourself?
Sure, I was just inquiring about the efficacy of spinal anesthesia in patients who happen to come in on naltrexone.
Yeah, so I don't know that spinal anesthesia is going to be effective because they're putting narcotics into the spinal. So the spinal anesthesia is local and some narcotic. So the local anesthetic will probably be effective, but the narcotic probably isn't going to be. And, you know, it would mean general anesthesia if they needed a C-section probably. They might be you might be able to convince an anesthesiologist to try and see what kind of level you get with a spinal or an epidural, but it would definitely mean cesarean. If they had a cesarean, it would probably mean general anesthesia.
It's Blair Walker. I'm with psychiatry. I mean, I know that in OB world, someone comes in and needs attention now, it might be, you know, that the person needs to go to a C-section, but at least for folks who show up with a femur fracture and are on naltrexone, you can give them enough opioids to overcome it, no problem. So I don't know, I'm not aware, I'd have to defer to anesthesiologists to know. I would always say, give it a try, but you probably use more opioids, spinal, and sort of see what happens. Like they really might have to uptitrate a lot more. Same with if someone's on Naloxone. Not quite as much, but my experience has been that we can overcome naltrexone no problem. So, but I don't know what the dynamics are with with CSF, if it's a little bit different than systemic.
Yeah, so we have generally not had issues with pain control on patients on Suboxone.
Mm-hmm.
But again, it's not the Naloxone that we're fighting, it's the Buprenorphine and that mixed agonist-antagonist response more than any Naloxone, because that's not really orally absorbed or in that formulation. There's a dose limit in CSF because you're going to end up causing a high spinal. So we can't just give all the opioids we want into their CSF. And again, we don't love we can use intravenous opioids for labor, but again, that's going right into the baby and causing respiratory depression. So we have some limitations here.
Great question.
So it sounds like specifically
Emily,
for naltrexone.
Go ahead.
Mm-hmm.
Sorry, it sounds like
Blair.
specifically for naltrexone, but not Suboxone, need to have sort of a labor plan and advance notice to try to get off of the naltrexone. Okay.
Yeah. And for buprenorphine, there's a lot of debate about what we should be doing around the time of labor with bup. I am in the favor of just stay on the bup and give some extra oxy if you need to, as opposed to stopping and doing some crazy fentanyl thing and hoping they don't overdose in the meantime. So I recommend just staying on the bup and working with your anesthesiologists.
Agreed. And I will just plug for people who might not know, splitting up the bup works really well for pain control. So 3 times a day or 4 times a day. We're in the trauma hospital here. Femur fractures, terrible, giant, gaping wound abscesses can be managed by Suboxone. So it just depends on the patient, and it depends on their pain thresholds and their mu receptors and polymorphisms, and probably their liver metabolism too.
Pregnant women are typically going to be on a BID TID dose of bup for their maintenance doses, that just because of their metabolism. But postpartum, you can sometimes tweak that dosing a little bit for pain control.
Thank you both. Emily, you had a question earlier.
I just wanted to clarify when you were talking about relapse versus exposure to opioids, and you were like saying the highs and lows are worse than Can you repeat that again? You said the highs and lows are because it's not dose specific or something.
Yeah. So the risk of neonatal withdrawal is almost just like a dichotomous. You've either been exposed to opioids or you haven't. There probably is some dosing threshold, but we don't know what it is. So when patients tell me like, well, I want to get it down as low as I can, like I really encourage them to, like, I feel like we are always using the very lowest dose that we can. I never give anybody extra bup just in case. We always use the lowest dose that we can, but dose is not directly related to opioid withdrawal syndrome. So the things that go into opioid withdrawal syndrome, besides just are you on opioids or not, include how you're taking them. Are you on a steady dose, or are you taking a bunch one day versus none for a couple days and then another bunch one day? So much like an illicit drug use pattern would be. It also has to do with other exposures. So smoking increases neonatal withdrawal, other medications that you're on, particularly psych meds, so benzos, gabapentin, antipsychotics, all increase your withdrawal risk. But it's not a direct dose relationship.
Thank you.
Thank you. Well, let's move on to announcements from the Texas Mood programming, just so we can get to our case. Echo IT, can you share the Texas Mood announcement slides? And while she's pulling that up, I just want to say thanks to all of you who have joined us for the Support Hospital for Hospital Opioid Use Disorder Treatment ECHO. That's Shout Texas ECHO. That's much better to say for short. Thank you, Echo IT. They look great now. So Texas Mood is the largest training and technical assistance center focusing on SUD in Texas. It acts as a one-stop shop for those working in addiction treatment and recovery services. Next slide, please. There we go. Texas Mood offers education, training, and resources and research for the SUD health workforce. Our clinical services are focused on expanding access to compassionate, evidence-based treatment and recovery support services for the uninsured. In the middle there, you see our telementoring efforts, which aim to improve the quality of care and expand our skilled treatment workforce across the state. So for many, this means the difference between life and death, active addiction, and recovery. We also give quarterly Get Waivered trainings that we can customize to groups who may be interested. And the group has trained over 800 providers across the state in the DEA X waiver. Next slide. Here we go. The Shout Texas is a program at Dell Medical School at the University of Texas at Austin and UT Health San Antonio's Texas Mood. The collaboration between them. It's working to increase access to substance and opioid use disorder treatment and harm reduction during acute hospitalization. Shout's mission is to expand a proven model of hospital-based treatment for opioid use disorder to all hospitals in the state of Texas. And to do that, they developed a robust collection of education and coaching opportunities, including these monthly ECHO sessions. Keep coming to these. We love seeing you all here. Monthly general office hours, bi-monthly OB-focused office hours, and expansion of a pilot program, which can include $35,000 in seed funding to start similar programs at hospitals across the state. Next slide. Just a promo of what's to come. You can join us at our next Shout Texas ECHO that's set for October 21st. We'll hear from our hub member, Chris, on delivering high-value care for SUD in the hospital. Next slide. We're also excited to introduce our Heroes Helpline, which is available to all first responders and healthcare workers, including allied health professionals in Texas. It is free and provides complete confidential telephone-based peer support and referral services to all first responders and healthcare workers in Texas. Our heroes have the opportunity to seek treatment without fear of judgment or stigma or occupational dilemmas. Screening and referral interventions assist individuals in overcoming barriers, addressing their mental health needs, and navigating them to treatment and recovery. So we encourage all of you to visit the heroeshelpline.org website for more information. Next slide. And here you'll see how you can sign up for all of the Shout Texas educational opportunities on our website. The next round of pilot seed funding will be opening in the fall. So if you or your organization is interested, please email the Shout team to get connected. That's at shouttx at austin.utexas.edu. Alana, I wonder if you could maybe throw that email over into the chat for folks. And then last slide. In an ongoing effort to provide better services and support to all of you, we want to request your feedback about today's session. So we're going to put a link a little bit later in the session to a post survey. And we'll also email that link out to you after the session is concluded. As a reminder, you only have to fill out this survey one time, and it takes about 2 to 3 minutes to complete. This survey is also how you get continuing education credits, and it must be filled in within a week of the session's close. That's all I have. You can stop that screen share. Alana is sharing a lot of good information over in the chat about registration for the next session, the email or the website for Shout Texas, as well as the email for getting in touch. And then again, a little later, look for that link about the post-session survey. Well, at this time, I want to turn things over to Tony, who's going to present our case for today. Echo IT, if you could pull up Tony's submission. Terrific. And Tony, when you're ready, tell us more about this client.
Okay, so this patient presents to the emergency room. He is a 32-year-old male, and he is eventually seen because he's in mild to moderate precipitated withdrawal. He takes quite a large amount of methadone every day, and it's illicit methadone that he obtains. He takes about 120 milligrams every day, and apparently his regular dealer just got arrested, and he's unable to find another source for illicit methadone. At the time, he talked to a friend, and his friend actually had some films of buprenorphine. It was a 8 milligram, 8/2 milligram buprenorphine films, Suboxone films, and he had some familiarity with Suboxone, but not a lot of familiarity. He has had an issue before in the past where he's gotten some precipitated withdrawal, so he knew that he had to wait. He just didn't really know how long. So he waited about 20 hours, and then he took a very small piece, just a quarter to like a third piece of the film, and then an hour after that, he started to have really terrible symptoms. When he showed up to the ED, he was in pretty severe withdrawal. He had a COW score of 12. He was given some IV fluids. He got some adjunctive medication seen there. He got a dose of Zofran, droperidol, clonidine, and acetaminophen over a course of 5 hours, but had only mild improvement of his symptoms. So the primary reason why he was admitted was intractable nausea and vomiting, and inability to tolerate PO secondary to precipitate withdrawal. So I guess my first question to the panel would be like, what would be your first treatment if you saw this patient in the ED, and what would you use first try?
You know, I wonder if, Tony, if it's okay with you, would you mind presenting on the rest of the case and those questions, and then we'll just lump it all in together at the close, in the last half of the session to discuss it all.
Sure, yeah, that'd be fine. So I guess what would be the first medication, and what other adjunctive medications that you've used personally that you anecdotally seems to really work, and why? This patient, he has a past medical history of opioid use disorder and marijuana use disorder. He also has a history of hypertension, to which he doesn't really take any medications for. And his hospital medications, he received, he had standing doses of acetaminophen, clonidine, and ondansetron ordered. In terms of his social history, he stated that he was close to his mother, who he lives with. He currently didn't have a job. His father didn't really know because he drank himself to an early grave, quote unquote. And he really doesn't have any other significant others and no dependents. In terms of transportation, he takes the public bus, or he, quote unquote, bums a ride from one of his marijuana smoking buddies, and he gets disability checks from a car accident a long time ago. His psychiatric history is a history of generalized anxiety disorder, major depression disorder. So in terms of hospital course, so upon admission, consult was placed to addiction medicine and medical toxicology, and it was to try and get control of his refractory symptoms. The decision by the team was to initiate micro-induction from methadone to buprenorphine. And it was done by giving a patient a full agonist dose of the methadone, as well as some adjunctive medications with clonidine and quetiapine over a course of 7 days. The regimen is as seen here, where he had 0.5 milligrams of the buprenorphine the first day, followed by a 0.5 milligrams twice daily, followed by 1 milligram, 2 milligram, 3 milligram, 4 milligram, and finally on the 7th day, he got a single one-time dose of 12 milligrams, as well as at the same time, he got cessation of all his other opioid agonist medications. Throughout that time, he didn't report any significant precipitated withdrawal, and he was discharged on day 8 with follow-up to an MAT clinic. In terms of any significant findings from his PDMP, it just showed very remote prescriptions of benzodiazepines. And he was stable on buprenorphine induction medication, 16 4 milligram films 30 days later on follow-up. So other questions I would ask the panel would be just, these type of like microinductions and other alternative buprenorphine induction strategies, has anyone come across any barriers to using these induction strategies? If any, and has anyone ever tried using these similar strategies to transition patients not from like buprenorphine to methadone, but just from like potentially to injectable buprenorphine or to injectable naltrexone? And that's all I have for the case. Thank you so much for having me.
Thanks so much, Tony, and thanks for pulling that all together. That is a lot to discuss. So I want to open it up to the group now. Are there any questions for Tony about this case? Well, we'll try it a little bit differently. What are some of the challenges you all see in delivering care to this patient? What is Tony encountering here? And to help us, I'm going to throw over into the chat because they were some pretty specific questions. What Tony listed on the form. Sorry if this is a large chat that comes to everybody. There we go. Just so you have that to refer back to.
Hey, Tony, maybe you said it and I just didn't catch it. How long, what was the time from the most recent dose before she got the bupe?
He waited about 20 hours after his last dose of methadone before he took the bupe, and that's then he presented to the ED an hour after that with the withdrawal.
So apologies, I had to enter a page. And I'm not sure what happened to our hub lead, but it was interesting when I looked at the case yesterday, not at all wrong what you guys did. So was he admitted for a week doing this microdose?
Yeah, he was admitted for a week to do this microdose.
And in the culture of your hospital, is that something that people are okay with? Just curious.
So the culture of the hospital was that at the time, no one really had done any this type of microdosing regimen at all, really. Like we had just started really a buprenorphine program in the emergency room and in the inpatient side like a year prior. And, it also was not very prevalent to have patients come into at least to my hospital at the time, which was at UCSD. We did not have any, a lot of methadone patients, specifically those that wanted to transition to buprenorphine. So it was like, first time?
So we have done quite a bit of microdosing over here now. Our lowest, so we have some, if we wanted to get tricky and use really tiny doses, we probably do V, but with our strips, we often will just tear in half. And so we've started people on 1 milligram, could probably get away with a quarter, although the pharmacists don't like us to do that. Just to start with sort of what we have on formulary. We have Suboxone strips on formulary here, but I've done microdosing with fentanyl drips, with methadone as well. I think what you guys did was great. It sounds like it worked great. I think for me, when I saw it, I went, wow, a whole week in a hospital to do that. Like I don't think my hospital system would go for that. I will also say, like, when I saw it, I thought, if I had been in the ER myself, I think I would have given the patient the choice of, you've already started your precipitated withdrawal with Suboxone, you want to just finish it. And I know it's a lot of methadone, and that might sound a little cavalier, and it might be because I've never done that. But I know that if he had come in full-blown precipitated withdrawal, my plan would not be to dose methadone. My plan would be to dose a ton more Suboxone. And I'm curious to hear what other people's thoughts are, because that's just my gestalt. And I think the caveat there is 120 of methadone is a ton. And so how do you build the opioid potency of Suboxone up to that? I don't know if you can or not, but I wonder what would have happened if you'd just given him an 8-strip and another 8-strip and another 8-strip and gotten up to 32 or even a little bit more that first day. Could he have just switched over? I don't know, and it may have been a rough ride. But sometimes patients are game for it. They're like, well, I can't get methadone out there. Like, so sure, let's do it and give them a day and see what happens. I can't imagine my hospital system being willing to admit somebody for just that. But it's a really interesting conundrum, because we're probably in the same position as you are. It's not easy to get people into a methadone clinic. It's near impossible, frankly, at least directly, quickly into a methadone clinic that's not out of pocket. I don't know. I could also see our hospital system being willing to help with the fee for the first week of the methadone clinic out of pocket or something, because our hospital system will do sort of out of the box things like that to avoid the admission and give like warm handoff to like one of our local partner methadone clinics and let them kind of work on that as an outpatient with them. And like, if you show up to do this, they're going to have to do that for a methadone clinic anyway. They'd have to show up 6 days a week. So that's another kind of workaround that I might have done, knowing that I probably wouldn't be allowed to get someone admitted for that reason. But it's an interesting conundrum.
Yeah, I think it was easier to have them do this regimen and have it done, because the alternative at the time to transition someone from methadone to buprenorphine at our hospital would have been a 3-week admission, where they slowly tapered the methadone down to like 30 milligrams, and then have them there was a protocol for like a 3-week admission transition period. So that, as opposed to a 1-week microdose, it was like a much easier sell.
Yeah, that makes sense. Did you have questions about like non-opioid-based withdrawal medicines? Was that one of the questions? Like, what other medicines can you use for symptoms?
Yeah, just like adjunctive, like
sure.
Recommendations.
I can tell you. So our psych hospital, which is our detox facility as well, one of our main detox facilities, and pretty much use the kind of commonly used medication. So I heard clonidine that you guys were using. NSAIDs are often used, like naproxen, Bentyl for muscle cramps, Vistaril or hydroxyzine can help with anxiety, but also kind of dry people out a little bit, because you get kind of runny nose and just kind of get antsy. We also use loperamide for the diarrhea, and then clonidine, like you said. I'm trying to think what else we often use. That's sort of the main cocktail of available kind of symptom-based treatment. But I'll say that everyone I hear from who goes through it, it's pretty miserable, even if you're treating the symptoms. So,
Yeah.
I mean, now that we've used Suboxone so often in our hospice with this B team work that we're doing in Austin, Suboxone works just so well and so quickly. I think that the interesting conundrum of this case, it's a great case, is how potent 120 of methadone is, and can you get the Suboxone up? I'd be curious to hear from our addiction psychiatrists who are on, because I'm a consult psychiatrist, but not addiction psychiatrist necessarily. If like what their thoughts are about just kind of going for it with more Suboxone, and do you think that would have been doable, or that's just like cowboy?
That's a good question. Let's leave it open for a little.
So I'm not addiction psych trained, but my reading of the literature, because we had a patient who was in precipitated withdrawal, was to go ahead and dose with higher doses of bup to help get out of the withdrawal. So I'm with you, Blair. I think higher doses of the buprenorphine would probably help in precipitated withdrawal from a methadone program.
Great. Jen, I see you nodding too. Anything to add?
Yeah, and I think Tony posed this question earlier. What about the idea of bridging with something like fentanyl or a long-release morphine during the time that you're having to do this long induction? And if you're trying to do a really short, rapid induction of the bup every 4 to 8 hours and have the patient undergo that withdrawal, what would be the, I guess, effect of adding fentanyl or morphine during that short period? I'm not sure if anyone else has experience with that, but that seems to be coming up in some of the case series and things that I was reading as a feasible alternative.
I think if I had another chance at this case, I probably would have done something similar, something like a transdermal patch of something, like most likely a large dose of, good size dose of fentanyl. He totally would have gone for it. I think he was game for a lot of things, actually.
Dr. Lavin, I think you might be our addiction psychiatrist on the call. I wonder if you have any thoughts. Not to call you out. Well, yes, to call you out, but. We'll throw those over in the chat. Actually, speaking of the chat, we have a couple of questions here. Sharon raised the question, does naltrexone help with cravings for meth? I'll just pose that to the hub team. An answer on that?
I'm sorry. I didn't hear everything that you said on that.
Oh, I was just
Does naltrexone help
in the
with
chat.
Yes. That's what so has been prescribed naltrexone to help with cravings of methamphetamines along with buprenorphine, or not buprenorphine, Wellbutrin. And does that really work? Does it help? I mean, they've told him he will go into straight detox if he takes it while using. So, my question is that really, I guess, a good combination?
It's a reasonable combination. Wellbutrin is often used, and it has some evidence. It's off-label, but to help people who are struggling with stimulant use disorder. It has some similar effects on the brain, specifically norepinephrine and dopamine. And I've had a number of patients who do find it helpful and like it. Now, I'm aware of great evidence for naltrexone and meth cravings specifically. It does have evidence for alcohol and opioids. And the idea is, and I don't know if we totally understand it as clearly as we would like to, the mu receptors are occupied by this medicine and kind of keeps them calm. Our receptors are very closely involved with some of our reward pathways. And so for opioid use disorder, you're also kind of occupying the receptor, keeping it calm. If you use opioids while you're on naltrexone, this is what we're getting at with the other case. If you use opioids while on naltrexone, the opioids won't work as well because the naltrexone binds really tightly to that receptor and won't let the opioid occupy it and take effect. But I'm not aware that using meth on top of naltrexone will have any effect on what the meth will do to your system. I would expect that you would still have effects of methamphetamines. So, but it's not unreasonable to try. And I think there's probably a subset of the population that do have some benefit from it. And it's always worth it to try as long as it's not causing any problems and it seems to be helpful. So I think it always depends on the particular patient and their buy-in as well. That they want this to work. They're taking it every day. You know, to some extent, taking these medicines every day is sort of like you're kind of reinforcing your commitment to sobriety as well. Sort of staying mindful of the fact that you're still trying to cut back or actually stop all the way, depending on what that person is working on.
Okay.
Dr. Waklu, Siddharth over at Southwestern just published this in the New England Journal, June maybe, looking at, I think they looked at the Vivitrol injection, though, the extended release naltrexone in combination with the Buprenorphine XL. And the results were mixed, but they had a tendency to use less. Was my takeaway from that article. It was the population was a little bit smaller, but it was well done though. But Blair, I think you're right that it's something, and as long as you can block with the naltrexone, block the mu receptor from allowing the dopamine to be released by inhibiting by stopping the inhibition of the GABA receptor in the ventral tegmental area, then I think you can at least make a fair argument that would ultimately reduce the dopamine transmission downstream to the nucleus accumbens. So yeah, Sharon, I think that's a very, very reasonable approach to methamphetamine craving.
Thank you.
Thanks for sharing that, Justin, and Jan, thanks for putting that over in the chat. And Alana has put in there that post-session survey. It's a great question, Sharon. Dr. Jan, could you lead us through maybe what you see are some of the key points and recommendations from this case today, and that's how we'll close out.
Sure. So today, I think the important thing to remember is that methadone, unlike other opioids, comes with its own challenges with transitioning over to buprenorphine. And so we discussed that we have a pretty high risk of precipitated withdrawal with a quick or a high dose of buprenorphine initially. And often the time that you have to wait for methadone to leave the system is prohibitive for patients and requires a lot of buy-in and a lot of support for them. There are different methods to try and do it, and some of the things that we discussed was microdosing the buprenorphine at certain intervals, Q12 or Q24 hours, to reduce that risk of precipitated withdrawal, or to bridge with something like fentanyl or morphine to sort of take away those withdrawal symptoms. But the fact remains is these patients will have a high likelihood of going through withdrawal symptoms, and really important to try to use all the adjunctive medications we have to help them through it. And the other things we discussed a little bit about the naltrexone component, and with bupropion, naltrexone, in the treatment of methamphetamine use disorder, and went over that recent paper that showed it may have some sort of effect size or effect on cravings for methamphetamine use. And I think those are the main things.
All right. Thank you so much, Jan. And Tony, thank you for presenting such a rich and interesting case. Thanks as always to all of you in our learning network and to Lorie for the wonderful didactics. We hope to see you again in mid to late October. Have a wonderful rest of your week. Bye-bye.
Thank you, everyone.